Okay, good evening, ladies and gentlemen. Welcome to this Teoxane Asia Pacific region webinar that we do on Wednesday. It's almost become a tradition now. We've got a very popular topic, eyes. We've heard many cliches, eyes that are windows to the soul, windows to the heart. We always pick up if people are fresh or tired looking at the eyes. So very popular topic. Being the pioneers with Redensity 2, which was first launched more than 10 years ago. We celebrated the 10-year anniversary last year. We're very passionate about this area, and we're very, very fortunate to have one of the global experts in periorbital rejuvenation, Dr. Tahera Bhojani-Lynch. I'm going to introduce her in a moment. I want to say thank you to all of you who have joined us. We've got about 200 people on the call from all across Asia Pacific region, lots of familiar faces. Thank you. Thank you for coming back. And please do use the chat box or the Q&A box, not just to ask Tahera any questions, but also if you have any topics, new topics that you'd want us to cover. I can't promise you that we'll do all, but we'll definitely find a way to do that. Helping me on this webinar tonight, Dr. Nadia Lam, who has joined us as a medical education manager for Asia region. You can see Nadia on the call, and who you can't see on the call is Melanie Leopold, who's the head of our events, who's always there with every event you've known and seen or heard about Melanie. So let's go to the next slide. We'll introduce Dr. Tahera. For those of you who have not heard her, Tahera, you are now in Thailand. It's the first time you were telling me before we came on.
That's right. Really delighted to be here. Thank you.
Fantastic. I know for those Thai doctors on the call, Tahera, we have not yet launched Redensity 2 in Thailand, which we're going to do very, very soon. I can't obviously give the date, but I'm sure they're going to hang on to each and every word of yours. As you say, I believe you're going to cover direct and indirect techniques with the periorbital rejuvenation with the Teoxane approach framework. So I'm looking forward to hearing your topic and your expert insights, Tahera. Ladies and gentlemen, for those of you who have not heard, as I was saying before I got a bit sidetracked, you've not heard Dr. Tahera. She is from UK. She has many qualifications here. She has a postgraduate qualification, laser kin therapeutics. I'm going to embarrass her. She's a qualified cosmetic scientist. She's a trained pharmaceutical physician. Don't ask me about my educational qualifications now, because I'm going to be very embarrassed. She's a full member of British College of Aesthetic Medicine. She sits on the faculty of the International Association for the Prevention of Complications. We will do a complications course with Tahera. I love that. We've done a few of those in many countries. She's of course, she's an aesthetic doctor. She's also a dermatologist and an ophthalmic surgeon. In case you did not know, as a member of the Royal College of Ophthalmologists, Tahera, you were the first female British graduate to perform LASIK in the UK. You're a certified laser refractive surgeon. You've done more than 10,000 surgeries. So first things first, where do you get the time to do all of these?
I think if you love what you do, you always find the time to do it.
Oh, my Lord, that's a nice one. Okay, all right, fantastic. Look, Tahera, you and I know that we have set up a poll. And for those of you who have joined us for the first time, we always want to start, mostly, we start with a poll so that we give you and we get a sense of what you're thinking related to the topic. So we've got about 7 questions, if I'm right, or under 7 questions, let's just say, to understand your thought process, your current practices with regards to how you're treating under eye aesthetically in your clinical practice. So if Melanie is ready, Melanie, could I ask you to bring up the poll, please? Okay, fantastic. I assume everybody has got questions come up on their computer or iPhone or iPad, whatever you're using. I can see some of you are answering them as well. I'm going to read out each question, give about 10 seconds. We go through the end of the questions, and I can see here we've got 5 questions, which is brilliant. We will end the poll, and the results will come up for you to have a look. We'll dialogue them with Tahera, and then she'll take it on and get into a presentation, making some comments about your insights. So the first question, how experienced are you with filler injectable treatments in the periorbital area? So we give about 10 seconds to people. No experience, novice, comfortable, expert. So let's see how the poll is rolling out. Okay, I think, Tara, you can see the results as well. Well, our audience may not yet see. You have a third and the third being comfortable. Probably comfortable is leading now with almost 50%, a third being novice, and about 15% being experts, more than 150 cases. So that's a good setup. You've got a nice bell curve here. We'll come back to that. All right, ladies and gentlemen, next question. What do you worry about when it comes to filler injectable treatments in the periorbital area? The product choice, safe technique, patient pain, or poor aesthetic outcomes? I think the leading one is poor aesthetic outcomes here. And by the way, my apologies. There is long-term.
I can't see question 2. Is that, I need to scroll down. Okay.
Yeah, you got to scroll down. Okay, that's a good one. I'm sure everybody can see the question. If you can't, please scroll down. So what do you worry about in the periorbital area with regards to your treatment? A, product choice, B, safe technique, patient pain, poor aesthetic outcomes, or long-term complications. And Tara can see poor aesthetic outcomes trumping. How often we hear that? How often? Everywhere, irrespective of the country. North Asia, South Asia.
I think that's the number. I think between poor aesthetic outcome and long-term complications, that's going to be 90% easily.
There you go. Yeah, agree. All right, let's go to the third question. When you are treating the periorbital area, do you use, it's a single choice question, A, needle only, B, cannula, C, I use both needle and cannula. Let's give it a few seconds, people, so that you can come up with your poll. Cannula is leading so far. Powerful. Does that surprise you?
It doesn't surprise me at all. I think especially the newer generation of practitioners, some of them have only been taught how to use cannula. And whilst there is an element of perceived safety in that, I always think, if you're going to build a house, you can't just use one tool. You can't build a house with just a screwdriver. You need a hammer and a screwdriver, you need more than one tool too. So I think extending your repertoire of skills with different tools is part of your growth as a practitioner.
Okay, yeah, right, good one. Okay, question 4. Currently, when you're treating the periorbital region, what's your go-to product? Oh, come on. Everybody's saying Redensity too. All right, thank you for indulging us. We'd like to see them translate into your preference. What's next? There is Vital Light, there's Bellatero Soft, and then any other product. Okay, that's interesting. So we'll let you comment on that, Tara, when we go to your presentation. You don't have to comment on that now. And then the last question, apart from filler injectable treatments, what other products or treatments do you provide to your patients in the periorbital area? A, toxin, B, energy-based treatment, C, skin boosters, and D, topical dermaceutical treatment. And you're seeing, okay, it's not a single choice, still skin boosters, toxin, and a bit of this and a bit of that. Your thoughts, Tara, on this?
I'm surprised there isn't 100% of people doing toxin in the periorbital area because, of course, the original chemical brow lift was done using toxin, and it's still, at least in the UK, the treatment of choice when somebody first presents in the upper part of the eye. But we will talk about that hopefully in part 2 of when we come back in a month's time with a few more tips and tricks. We'll talk about how we can add to the filler treatments with other things, including some of these.
Yeah, that's right. That's a good point. So, ladies and gentlemen, please tune in 20th of March, part 2 of this webinar. Tonight, it's going to be direct and indirect mid-face and under the eye treatments, probably simpler techniques, and under eye hollows, temples, potentially are going to be covered in the next segment, which is on the 20th of March. So you can stick on to that. Let's summarize for you And we have a slide come up right at the end of this presentation so that you can mark it in your diaries for 20th of March, part 2 of this under eyes treatment behind those bright eyes. Okay, Tahera, to sum up, we asked 5 questions. How experienced? More than 50 cases is half of the people, and 30% are saying no, less than 10 cases, and about 12% saying I'm an expert. More than 150 cases, and we do have people who have no experience. That's about 7%. And then we asked them, what do you worry about when it comes to filler injectable treatments in the periorbital area? And as you said, the poor aesthetic outcomes and long-term complications trumpet 100%. If you add up, technique is a clear expectation. I want to say technique. More than half of them is saying, and a third of them saying product choice. You were not surprised with cannula being 50% of the use. When we asked them needle, cannula, both, and there was a product selection question, they're being kind to Teoxane. And on the last question, what other treatments do you use? And you did say you were surprised toxin wasn't 100%, there was popping up 3/4. So that's a good summary, Tahera. I think you have a sense of what people are thinking, what they're doing. And I hope you, as our audience tonight, you also felt related, if you will, to other clinicians in the region or whoever is delved into this webinar for the matter, and their practices are part of this webinar. When we do this polls, is peer learning, and I feel a lot reassured hearing what you're doing compared to what others are doing. So I think that's a good setup for now, Tahera. I'll let you switch computers between Melanie and yourself so that you can start sharing your presentation and talk us through your views behind those bright eyes, your approach to periorbital rejuvenation using Teoxane approach. Tahera, over to you.
So hopefully, are you seeing my screen now?
Yes, we are seeing your screen. Once you make it full screen, then I can go off screen.
I'm trying to get rid of your screen because I can still see yours. Let's see.
Yeah. Once you click on the first slide and go full screen, then we're in business. You may want to click on the slide 1 first. So you got to go back.
So your screen is still showing on over the results of the poll is still showing on my screen. So I'm just going to close that. I'm here. Okay.
Yeah, all right, fantastic. You're good, Tahera. Take it away.
So thank you everybody for joining us in this very warm evening in Thailand. I came from terrible weather in the UK, so it's absolutely delightful to be here. And if you are happy to look at the QR code, and you can always share questions with me afterwards. I'm always happy to hear from people all over that have listened to the presentations. So just let's see if I can move on. So we've got a fairly packed agenda to try and cover in the next hour or so. We're going to just talk about the anatomy of youth and aging, and how the areas that we are looking at change as we get older, and then how we can assess those in order to be able to do a safe and effective correction. It was interesting in that poll that about 70% of the audience were either comfortable or experienced in injecting, and yet about the same number are also worried about aesthetic outcome and long-term complications. So it's interesting, isn't it, that this area, even though you're very comfortable injecting it, always at the back of your mind, you're worried about poor aesthetic outcome, because there are some complexities to the area that unless your knowledge of anatomy and assessment is good, you can still sometimes have difficulty. So it's not a reflection on your expertise. Even people with 100 cases still worry. Even me, after over 1,000 cases, I still worry about aesthetic outcome. You have to keep your eye on the ball the whole time you are injecting this area, otherwise you run into difficulty. Okay, and then we're going to talk about the different techniques, something else that was mentioned in the questions. Different techniques using needles and cannulas. I'm going to show you both today, direct and indirect. And then we'll talk about why product selection is so important in a predictable aesthetic outcome. that the predictability of your result and the long-term complications has a direct correlation with the product that you use. And then hopefully we can look forward to part 2 in a few weeks' time. So those of you who know the Teoxane approach know that we have a very specific way of teaching. We talk about assessment and anatomy, because unless you know how to assess a face and unless you understand the anatomy, you are not going to get a consistent result or a safe result. Then we will talk about techniques and treatment plans, because before you put the needle in the skin, it is absolutely imperative that you know what is going to happen when you press the plunger. It takes 10 seconds to do an injection and a lifetime to regret it. If you know what's going to happen when you press the plunger, you have no worries. And then we'll talk about product choice and why it's important. So before we start, just some quick recaps for the less experienced of the terminology. There are lots of different names for the different bits of your face. And we often talk about tear trough as this sort of general area here. But truly, the actual tear trough, anatomically, is just the bit from the corner of your eye to the middle. The medial tear trough is the true anatomical tear trough. If the tear trough extends to the lateral aspect, we call it the palpebral groove. In Latin, anything that is palpebral is lid, anything that is malar is cheek. So palpebral groove is the lid-cheek junction on the lateral aspect. And then there are some other terms. We obviously have the nasojugal groove, which runs from the corner of the eye down the side of the nose, slightly medial to the tear trough, because it's usually where the vessels run. So your angular vein usually runs in the nasojugal groove, and it sometimes has a little dip. Okay, we often see dips in the surface where there are vessels. Yeah, same here. And then if you see the groove in the cheek, that malar groove, I often call it the separation of the malar fat pad. You see it when there's loss of the deep medial fat compartment and laxity of the skin. Okay, so these are important landmarks for you to bear in mind that we often think about as tear trough treatments, because they're kind of all attached to one another. Okay, so in this area, your tear trough, your palpebral malar groove, and your mid-cheek groove, they all coincide together at this point. And this is usually where your medial souph, the center of your medial souph often sits here. So often if you actually treat this one point, you can get correction in all 3 areas. It's an interesting, important point that if you have a restricted amount of product and you want one place to put the product, yeah, it's the center, I call it the center of the Y point. It's like a Y-shaped groove. You lift at the center of the Y point, it makes a nice difference. So how does the anatomy change as we get older? And how does the anatomy differ in different parts of the face? So most injectors now understand that there is layered anatomy of the face, that we have 5 important layers in the face that we have to respect when we are trying to treat aging. The outermost is your skin, your lowest is the bone, and in between we have 3 very important layers in most parts of the face. So we have superficial fat, deep fat, separated by the muscle. And the superficial fat and the deep fat are specific and they are different. And this is a very important differentiation that you need to bear in mind, that the bone and the deep fat are structural. So they are static and they do not move. So the bone and the deep fat are static. So if you think of your face as a bit like a bed, the base of the bed and the mattress are static and they give shape and support to your whole face. The top surface moves. When we smile, it's mobile. It's like having a duvet or a quilt on the top surface of the bed. It moves. You can stretch it, you can squash it. It's a dynamic layer. Okay, with the muscle underneath and the skin on the top, like the cover on your duvet. Okay, stretch it, everything is affected. That is an important thing to remember when we are looking at how we are going to reshape the face, because all of these layers, every single one of them changes with age. The bone changes, the deep fat changes, the muscle changes, the superficial fat changes, and the skin changes. So if you want to make somebody look younger, fresher, naturally, looking healthy when you do it, looking normal when you do it, you have to think about all of the layers, not just one layer. Okay? And then when you look at that, let's just go back, when you look at that coming across the cheek, in the under eye area here, in the lateral aspect of the under eye, you have all 5 layers. The further towards the eye you go, the thinner the layers get. So here you have skin and superficial fat, skin and superficial fat, skin and all of a sudden you get here, you get to the eyelid and you have just skin. And you can feel that on your own face. You get here, just skin, no fat. Similarly, as you go laterally to medially, you have deep fat, superficial fat, and as you come more medially, you get to the tear trough. There is no deep fat, there is no superficial fat. It is skin, muscle, bone. And that's very important to remember, because when we put filler in our faces, when we go deep to the muscle in most of the face, we are going to that deep fat layer. You may be going on bone, but the product sits in the deep fat. Similarly, when you go under the skin, usually the product sits in superficial fat. So if you're coming in an area like the tear trough, where there is only skin, muscle, bone, and there is no fat layer for your filler to sit in, you have to think, where is the filler going to sit? It's either going to sit above the muscle, and you will see it because the skin is thin, or you have to put it as deep below the muscle as possible, between muscle and bone. And then the product is going to sit deep in the intramuscular layer. So whatever you put there has to be able to move with the muscle. So if it doesn't move with the muscle, it will become rigid and it will show as a bulge. You're already beginning to hear, I hope, why product choice becomes important in these areas. So what happens to these layers that I've just described as we get older? So we know that bone shrinks and resorbs and redistributes with age. So a young orbit is almost round. Okay, the muscle is dense at the temple, it's dense along the zygoma. And as we age, the shape changes. It goes from being rounder to being more square-shaped. You end up with a lip on the lateral aspect, which sometimes causes prolapse of the fat behind the eye. The orbital fat can actually leak out of here and cause bags. Okay, you can see that even things like your supraorbital foramen becomes a supraorbital notch because the bone is thinning, and even the temple bone resorbs and become very thin. So these are all bony changes. Even in the maxilla, in the mandible, everything shrinks. You know, elderly patients, their chins, they collapse in on themselves. They get smaller and smaller because even the jaw bone reduces in size. Working our way through those layers from bone to deep fat. The deep fat, remember, it's structural, it's support, it's the mattress in your bed. In the under eye area, there are 3 very, very important fat pads. that are absolutely imperative to the structure of the midface and therefore to the structure of the under eye. So we have medial soothe, lateral soothe, and deep medial fat compartment. Medial soothe stands for suborbicularis oculi fat pad. Lateral soothe, lateral fat pad, and deep medial fat compartment sits below. I want to stress something very important. Your medial soothe is not at the medial part of the eye. Remember, the tear trough, there is no fat under the muscle. Medial soothe sits under the lateral aspect of the eye. Medial soothe sits from your mid-pupillary line to your lateral canthus. So it is not medial to the eye, it's just more medial than lateral soothe. So your medial soothe sits here. Your lateral soothe sits from lateral canthus to your orbital margin. Medial soothe, lateral soothe. Deep medial fat compartment sits below medial soothe, doesn't sit here, because there's very little deep fat here, mainly superficial fat. Medial soothe, lateral soothe, deep medial fat compartment. They are what give your cheek the curve, youthful, pretty curve. And it is loss of these fat pads that contribute to the orbital hollow. Okay. So when we're young, they fill this area. As we age, they drop and they shrink. And you get flattening of the face. And you get exposure of the orbital rim. So the appearance of the space around the eye appears to get bigger. Next layer, muscles. Okay, so we've done the structural part, the part that doesn't move. We're now coming on to mobile layers. So we have a mobile layer, which are your muscles. And the main muscle in this area is your orbicularis oculi. And it has two parts to it. The circular part, which is, we call it the orbital part, because it sits all the way around the orbit. And the palpable part, remember what I said palpable mean? It means lid, the little bit that sits on your lid. So orbital and palpable. Okay, the orbital part of orbicularis oculi, its main function is as a sphincter. It actually closes and opens the lymphatic drainage and the scrunching of your eyes, which is why when we put toxin, we take away a little bit of orbicularis oculi here, because it's that pull in and scrunch. It does this. Orbicularis oculi is tight here. It's tight here. It's tight at the corner of the eye. And its action is like this. That's really important for you to remember, because if you have something that is really mobile and you put anything above the muscle or on top of the muscle, and if the muscle is doing this, over time it is possible that anything sitting on top of it will also move with it. So putting filler in this part of the face requires important product choice and should be done with care, because this is where you can sometimes get filler migration from the movement. Similarly, we see it in the lips because of the movement, we see filler migration. Similarly, you can see it under the eyes if you are not careful. Okay, remember, fat doesn't migrate because it's compartmentalized, it's very lightweight. Dermal fillers carry water with them, they are heavier. It's easier for them to move. Easier for gravity to take its effect on them. Okay. Movement, product choice is important. The other thing you have to remember is the ligaments that hold the muscle in place. Ligaments are, when we talk about sort of bone to skin ligaments, we call them osteocutaneous ligaments because they go from the bone to the skin. Okay. In the medial aspect of the eye, we see this kind of whitish color in the corner of the eye. That is because there is this ligament that attaches all the way from skin to bone. And it's held tight. Here we don't have the same ligament at the corner of the eye. So one of the things that happens as we get older is the corner of the eye drops and rotates. As you lose laxity to the skin, as you lose support to the midface, your corner of your eye drops. And most of the evolution of the tear trough comes from the downward and inward rotation of the skin. When we see someone saying, I don't like this groove, if they are in their 20s, they haven't had this drop of their skin because they still have young, tight skin. That is more likely to be because they don't have fat support under here. But if they are in their 50s and they come with a tear trough, it is more likely to be from the drop and rotation of the skin. And if you've got drop and rotation of the skin, then the easiest way to correct it is not to fill here, but to lift from here. You will see a better result if you do that before you do that. And we will talk about how we can do that in our assessment and our treatment when we talk about direct and indirect treatments. I can see there are a number of hands being raised during the talk. What I propose is that I'll just keep talking. I'm not ignoring the questions, but then we'll take them at the end if that's okay, and we'll go back and recap everything that you need to. We have loads of time if we, to cover all of these questions. So we're working our way through the layers. I know anatomy is boring, but it's really important if you want to get this right. So now we're coming to superficial fat. So again, this is your mobile quilt on the top surface. Superficial fat moves. And superficial fat layers, the majority of them in your face shrink with age. And, most children have really kind of fat faces, and then we start to lose the superficial fat over this part of our face first, because superficial fat is most lost under muscles that move the most, right? It's like, runners have skinny legs because their superficial fat is lost over the muscle that is working. So when we eat and we chew throughout life, this loses muscle first. The amount of movement we have in the under eye, around the mouth, superficial fat pads disappear first. So this is one of the first superficial fat pads to shrink away. And when we lose that superficial infraorbital fat pad, we get bearing of the orbital rim. And that combination of the deep fat support loss and the superficial fat, if we take it as a collective, when we're young, it's big and round. And as we get older, it drops and the orbital rim bears, and that's what we see as the tear trough. And just to kind of put that in perspective, that you get this exaggeration of your nasolabial fold, and you get this exaggeration of the under eye. Combined with loss of skin elasticity, you get, and the rotation of the skin, you get this tear trough deformity that we are all aware of. The final layer, of course, is the skin. And just bear in mind that when we see tear troughs, usually it is the shadow caused by the loss of volume or the absence of small soothe. But there are other things that make the under eye look unattractive. Pigmentation, either from sun, because when we're younger, we have big fat cheeks. The sun is high in the sky. This area gets pigmentation. This area gets pigmentation when the sun catches it the most. So you can get freckling and darkening just from the sun. You also get pigmentation from friction. So anywhere on your body where skin is folded, the skin looks a little bit darker. So if you have a fold here for a while, if you actually then displace the skin, you'll often see the color of the skin is different. And it's post-inflammatory pigmentation just from microscopic friction. And if you lift the skin out with a filler or you improve the tear trough, because the skin is not folded, over time as the skin sits not in a fold, often the skin will lighten on its own. Similarly, if you use a depigmentation product, it will help. And then, of course, skin is getting thinner, you see the color of that skin muscle bone. We said there's no fat there, or the fat has disappeared. So then you can see the color of the muscle under the skin. So if you do something to redensify the thickness of the skin, you can also make the darkness look better. So I'm already giving you different treatment modalities for the under eye area. You can treat the tear trough, you can treat the thickness of the skin, or you can treat the color of the surface of the skin. All of these things will improve the under eye. I like this picture mainly because it shows that loss of elasticity. Can you see the drape of the skin? It comes, instead of going up around like that, it's dropped down like this. I'm going to show you her before and after picture a bit later on, where we've actually lifted the corner of her eye and draped the skin upwards, treating her medial tear trough by treating the lateral aspect of her eye. So, anatomy of aging, we've covered. Anatomy of injection. How do we keep the injections safe? So, there are some big vessels that we need to be mindful of when we're sticking needles and cannulas in people's faces. I always think it's more important that you choose the right layer rather than the surface landmark. If you're in the right layer, you can avoid the vessels quite easily. All blood vessels, all big blood vessels, are there to feed the muscles primarily. So if you're in deep fat, if they're deep to the muscle, they will be underneath the muscle plane. If they're superficial to the muscle, they'll be above the muscle plane. So if you go in the superficial fat or the deep fat, you need to go to the top of the superficial fat, you will avoid the vessel. You need to go to the bottom of the deep fat, you will avoid the vessel. Obviously, if a patient is very thin, you don't have much leeway, but that's one of my things that I find helpful, is to know that if we go as far deep as we can when we're going deep, or as far superficial as we can when we're going superficial, we are safer. Okay. Potential vessels coming out of the periorbital area. Of course, we have the angular artery, either down the side of the nose or in the medial canthus. We have the angular vein, which runs in the nasojugal fold. And we have the infraorbital artery that is below, and it comes out of the infraorbital foramen underneath the zygomatic arch. Okay, how do we avoid these? Well, the easiest way, you can draw a line from the corner of the eye downwards and stay lateral to it. You can draw a line in your mid-pupillary line and stay lateral to it. What does that tell you now? That lateral is safer, generally speaking. So to me, what I usually do is either you can draw your mid-pupillary line, as long as you stay lateral to that, you're fine. Actually, your infraorbital foramen is actually on the line of your medial limbus. So your limbus is where the colored part and the white part of your eye meet. This is your medial limbus. So that is normally in line with your infraorbital foramen. So if you are lateral to the medial limbus, you are likely to be safe. Similarly, the infraorbital foramen is underneath the zygomatic arch. So if you stay on the bone, you will be reasonably safe. So to me, 2 finger breadths or keep to the lateral aspect of the limbus, you're going to be fine. So on the zygomatic arch, lateral to the medial limbus. Okay. And then there is an artery on the cheekbone here, your zygomatical facial artery. And it tends to sit beyond the lateral, or in line with the lateral margin of your orbital rim. So you've got the medial margin and the lateral margin. If you come down, your zygomatic facial artery is about here. So again, if you stay medial, so you have quite a nice wide area here, which is where your medial sufa is. within the medial sousp, straight onto bone, you will be reasonably safe. Okay. So we've done the anatomy of aging, we've done the anatomy of depth for your injection. Now we're going to look at faces and how do you assess the face? How do you decide what you're going to do? So first of all, look at the things that are making, does the patient have a groove? Do they have something that is making the groove look worse? Do they have pigmentation? Do they have thinning of the skin? Do they have changes in their fat? Have they got loose skin? Remember, if the skin is really loose, even if you fill the face, if you're going to put enough volume in the face to stretch the skin out so it's not loose, their face is going to be out here. We've seen those people, haven't we? Where you think, okay, I want to lift, so I'm going to fill. You can only lift by projecting. And then they end up with this big fat face, even if they've got a tight jawline and they look odd. So remember that to lift skin, you have to have low loss of elasticity. If you have lost the elasticity of your skin, you are going to have to put a lot of filler to lift. And that is not going to be the right answer. Okay, so if somebody has festoons of skin, loss of elasticity, the amount of improvement you are going to get just by filling them is very limited. They are going to need things that are going to tighten their skin. Okay, if they've just got changes in their fat, you can give them more fat by putting filler where they used to have fat. They have thinning of their skin, you can give them things to redensify their skin. They have changes in the color of the skin, you can do things to improve that. The main thing is, do you have enough space to fill the grooves? In which case, we will be able to put in filler to fill the groove. When we are looking at, you'll often see this demonstrated as a way of deciding whether somebody is suitable for a direct tear trough treatment. Look for elasticity in their snap test. Look for a negative or positive vector. Check to see if they have edema. Push test is the only thing I really do. I look to see volume loss, and I just look at their general elasticity. The snapback might give you an idea, but ultimately, if you see their skin hanging and you do a push test, if you're going to have to push this much to lift, that tells you everything you know. How much you're going to have to push to get the lift. It gives you an estimate of how much product you're going to need and what the patient's expectation is. If they're expecting to look 20 when they're 60, just with filler, they are going to be very disappointed, or you're going to have to put so much filler in that when they're done, they are not going to look like themselves anymore. Okay, so they're the things you have to weigh up. If you see someone with a negative vector, usually you can get away with a direct tear trough treatment because they've still got reasonable volume in their cheek. Okay. So direct tear troughs, of course, loss of the deep fat, tight skin, thick skin, mild eye bag. So we're talking about young patients generally will do well with a direct tear trough. Anybody that is probably over the age of 40 is going to do better with an indirect tear trough first, because they will already have some degree of sun damage, some degree of skin thinning, some degree of volume loss. I love this slide because it shows that when you lose the fat and all you've got is skin, muscle, bone, you can see exactly where a tear trough and that deformity comes from. It comes from the loss of the fat. You can see where the superficial fat has been lost, where the deep fat has been lost. And the actual shape of the orbit is completely visible. So, how do I assess tear troughs? I don't really go in much for the SNAP test or that. I read this piece of research more than 10 years ago, and it changed the way I assessed tear troughs. And to this day, I still use it. It's quite a simplistic way of doing it. I find it very useful when I'm teaching. To grade the tear trough. So this person, Barton, published a tear trough grading scale. And he or she said that you can grade a tear trough from 1 to 3, well, from 0 to 3. 0 means there is no groove. Okay. Grade 1 is where you have just medial tear trough. Grade 2 is where you have a medial tear trough and a lateral tear trough. And that equates to loss of your medial sieve and your lateral sieve to some extent, or maybe just your superficial fat pad. A grade 3 is where you have a demarcation in your cheek. And that is definitely when you've lost medial sieve. So you can lose the superficial fat pad and just have a superficial tear trough, or you can get a demarcation here because medial sieve has also been affected, and lateral sieve, depending on how far that demarcation is. Okay. And then I added to this. I thought, okay, I'm going to do my Bhojani tear trough grading scale, because if you actually then also lose your deep medial fat compartment, you get a separation of the groove, and we see that in older patients. And if this is the order in which the face ages, then if you're going to reverse the aging, you should start with the hollow here and work backwards. And that's actually now how I do all my tear trough treatments. I start by, if they have a groove in their cheek and they've lost their deep medial fat compartment, I will lift that first. I will then treat their medial and lateral sieve. If you treat the medial sieve first, the lateral sieve will correct automatically because it gets pushed out again. And only when I've corrected mid-face and the medial sieve do I then look and see, does the tear trough actually need any product? And by doing indirect tear trough treatments, the majority of patients over the age of 40 can be successfully treated without ever having to go directly into the tear trough. And I'm just going to show you some examples of this. So this woman, when she first came to me, she was 67 years old, and her tear trough, you can see she has a groove here, so she's at least a grade 1, and she has a groove here, so she's at least a grade 2, and she's lost this support here, which is her medial sieve. So she's at least a grade 3. She's lost her lateral sieve, and she's lost her deep medial fat compartment. She's got separation. So she's got a grade 4 tear trough. And what we did for her is we filled her medial sieve, we filled her deep medial fat compartment. We did a little bit in her lateral sieve, not too much. But you can already see that by treating this part, we made this look better. And because that was age appropriate, even though when she came in, she complained of her tear troughs, and we only treated her cheeks, when she came back for her checkup, she said that she was quite happy with her tear troughs, because you can't have no groove here when you are in your 60s and still have loss of volume here. So it's entirely inappropriate to treat just the tear trough in somebody whose whole face has collapsed. Of course, that makes sense. We're going to go down the decades. So this lady was 51, and she has a medial tear trough. She has a lateral tear trough. She's lost her superficial fat. She's lost her medial sieve support here. Lateral sieve, not too bad. You can just see the beginnings of the loss. And we treated all of those, nothing directly in her tear trough, just mid-face, medial sieve, lateral sieve. Okay? So she is postmenopausal, her skin is loose. So she's had good correction. but she doesn't get much lift because her skin is not tight. Here's somebody who's premenopausal. We did exactly the same treatment with exactly the same product. And you can see that it's actually recreated the V shape on her because her skin is tight. So we treated her deep medial fat compartment, lateral sieve, medial sieve. You can see how nice it looks when you treat somebody's lateral sieve. And because she is slimmer and because she is younger, the skin is tighter. And then we get into those younger patients that really haven't got any volume loss. She has a little bit of a notch here because naturally her medial sieve is not as big. And she has this discoloration of her skin because it's been sitting in a groove for a long time throughout her teenage years. She was only 24 when she presented, and she had had eye bags since she was 16, 17. Okay. And of course, we treated her medial and lateral sieve, and I gave her a little bit directly in her teardrop, a very small amount. And in her case, I also placed a tiny bit of filler in the lateral aspect of her cheek to draw the fluid away. So you can do this, you can actually take fluid away from the under eye by using the hygroscopic properties of hyaluronic acid. Bearing in mind, if you do it in an older person, they will get festoons because their skin can't take fluid. But in a young patient, having a bit of fluid under the skin here or drawing, it just makes the skin look glossy. You can see she's just got a little bit of projection here. Doesn't look out of place because we've taken the fluid to a lateral point. Techniques. So we're going to talk about how we achieve these results. So direct tear trough treatments. This is a beautiful video from my colleague Patrick Treverdick. I'm going to just talk you through the technique he uses for a direct tear trough treatment. So notice that he's going in with a cannula. That's his entry point, medial to the lateral canthus and lateral to the midpupillary point. And he's going to go deep with the cannula in that deep intramuscular layer. So as close to the bone as possible, but remember the muscle is attached to the bone, so you're not quite on bone, you're deep intramuscular. And he's putting just the tiniest droplets of product in the under eye area. Okay. And it's a fabulous result. So you can see he just did direct tear trough, which is why she's still got a little bit of deficit here on her lateral aspect, but it's a pretty nice result. Just to recap, when you're doing direct, you want small quantities, you want to inject very slowly, and you're going deep, supraperiosteal, deep intramuscular injection. And this is what we do when we're doing a direct tear trough. You can also use it to do the palpebromolar groove. And you would, if you sometimes, even if you're going direct tear trough first, you would still make sure that they don't need something in their cheek. So now we're going to show you a indirect tear trough treatment. So this is my patient, and she is quite young. In fact, I'm going to put the volume on this. I'm assuming you can hear it. If you can't hear it, you're going to shout, tell me.
Dr. Tahera, we can't hear it.
Okay, I'll talk over it. Sorry, let me just. I'm going to play it and I'm just going to talk you through it. So what I'm doing to begin with is I'm assessing her face, and we cleaned her properly before we started, but I'm just assessing her face. So assessment is always done in up gaze So we actually ask the patient to look up. I'm going to get her to look up in a moment. So there you go. And it exaggerates the defect. And you can see I've drawn in her medial groove, I've drawn in her lateral groove, and she's just got the beginnings of a little notch there. In fact, when I squash her face, you can see it better. And that tells me that her medial soot is deficient. Okay, so I'm looking, so do you remember I said there's you can draw in a Y, and the center of the Y point is usually the tip of the medial soot. And using that as your first injection point is often a really good place to start if you're doing just somebody's tear troughs and you're doing them indirectly. So you can see she's looking up, I'm finding that notch, and I've just put the needle down onto bone, okay? And I've done 0.1 of redensity 2 in where her medial and her lateral groove meet. So I just asked her how much it hurt, and I said on a scale of 1 to 10, and she said 2. Okay, remember redensity 2 has local anesthetic in it, so it numbs as it goes. So already you can see the correction compared to the other side of just 0.1 at the tip of the Y point. So now I'm just going to work my way along her medial soot deep. So a lot of people will use a thicker product in medial soot because it is a fat pad. You could use redensity, you could use RHA4, you could use RHA3, you could use RHA2. People say that. I use redensity 2 because if the product migrates, it's soft. And she's so slim, she has very little fat here. You can actually come right to the tip of her soot, just where it meets the beginning of her medial tear trough, and correct it and go into the fat pad or deep intramuscular, down onto bone, and still get a very good correction. So the first thing I did was correct that. And then what I'm doing on the side there is I'm actually just lifting her lateral soot. And when I do that, you get a little tilt to the corner of her eye. So can you see that the corner of her eye, and now I'm just going to lift her lateral canthus, little needle down to bone, underneath the ligaments and the muscle, underneath the muscle actually here. Remember, the ligament is not to the skin, just under that osteocutaneous ligament under the muscle, to stretch it so that we get some stretch to the skin. Remember that the origin of this is when this drops and rotates. So if we stretch it up from here, you get a pull upwards, and you can already see that that's what we're doing. So I'm just looking to see where she's lost fat, feeling for the deficit, dropping my needle down. And I don't know if you saw that, needle went down, then I flattened it so that the bevel is flat to the bone. So you get a smooth spread of the product in that deep plane. Okay. And you can see how the corner of her eye has lifted compared to the other side, and then we just go ahead and do the same thing. So into that center of the Y point. And you see, after every injection, I assess her face. After every couple of injections, I sit her up, because keeping an eye on how it looks while you're injecting is very important. And assessing people sitting up is very important. So I'll probably get her to sit up in a moment. And I'm just going to forward it on now, because we're going to get to the end, because you've seen it done on one side. I'll just let you see that outer canthal lift before. So this is where you're lifting the corner of the eye, needle down onto bone. Remember, good injecting is a bimanual technique. You can see I'm using my non-injecting finger to protect the orbital margin. So you can see that the product, or you can feel the product as it spreads under the skin. And you can just see the tissues lift. Okay. And I'm just going to fast forward now till the end because we've seen the technique. And that's her before and after. Indirect tear trough by treating medial sieve, lateral sieve, outer canthal lift. Can you see the difference between the shadow here and the shadow here? Okay. So if you're doing indirect tear trough treatments, start with your medial sieve before you do the DMC and the lateral sieve. So medial before lateral, but remember medial is not here, medial is here, medial sieve. Do as a two-stage approach. If somebody really needs an indirect, sometimes they need their cheeks first. I did not do that in her case, but you can certainly see as they get older, she was only 35. 40 plus, they will definitely need cheeks first. And if you're doing a multi-layering technique, do the deep first and then the superficial, is my advice. Okay. Just remember your depths, right? Superficial means superficial fat pad, deep means under the muscle. Okay. How do we decide what product we're using? So let me just remind you, in the lateral aspect of the eye, you have deep and superficial fat. In the medial aspect of the eye, you only have skin, muscle, bone. Filler normally sits in the fat pad. That's why it integrates and looks and feels natural. Your own fat is jelly at body temperature. So when we put jelly filler in jelly fat, it's just jelly. It moves normally. And when we put it in that deeper layer, you can even put it all the way down here and it sits like bone. So when you're putting something in that subcutaneous fat layer, it has to move normally. If you put a non-mobile product in a mobile part of the face, this is what happens. You get golf balls. And it looks horrible. So when people ask, why is it so important that we use this product or this product? This is why. You have to have a product that will move like your own face. Not sit like a walnut or a chestnut in your cheek. Because then it starts to all look a bit weird. And of course, we have to remember that there is a natural anatomy. Patients come in and say, just treat this, or just treat this, or just treat this. But if you only paint half a room, it is not the painted side that is the problem, it is the unpainted side. When you just treat the eyes, or you just treat the lips, having 20-year-old lips on a 40-year-old face, even if they are perfect, they don't fit the canvas. And you have to remember that just treating one area will give you a mismatch. So whenever you're thinking, if a patient says, I don't like my tear trough, look at the whole area. I don't like my lips, look at the whole area. Don't be single-minded. Don't treat the symptom. You are doctors. Treat the cause. You can't give paracetamol for a brain tumor just because they have a headache. You have to treat the cause. Don't just treat the lips, treat the whole area. Don't just treat the under eye. So Teoxane, the Teoxane range of products is incredible. You actually have a product for every layer of the face. If you want something to mimic bone, you have a product that has bony projection and stiffness. You can put ultra deep on bone, it will behave like bone. If you want something to mimic deep fat that gives you structure and support, you've got RHA3, RHA4 will actually mimic deep fat. And if they you happen to have a bit left and you want to put it in the superficial fat plane, you can, because all of the 1 to 4 products will integrate in that subcutaneous fat layer, and they will move like normal skin. They will move like the quilt on the bed without being lumpy, bumpy, stiff. And of course, we have Redensity 2, which is designed because it has so little water drawing in properties. It is less hygroscopic. You're not going to get swelling and overcorrection. And the product integrates very smoothly in that deep intramuscular layer. And we've got skin boosters and lip products. I mean, it's the full range of superb, well scientifically thought out products. What is the science behind it? Most people are not interested in rheology. They just want to inject and see a result. But if you think about your own natural hyaluronic acid, so natural hyaluronic acid has long chains. It's like spaghetti in a bowl, long chains, or noodles in a bowl, long chains. And you can pull them apart, and when they get close, they stick together. And when you pull them apart, they move and then they stick back together. That's what your normal HA is like. Back when hyaluronic acids were first made, what I now can say are, first generation hyaluronic acid fillers. So remember, the first was Restylane. It was a first generation hyaluronic acid. And it had particles and gel. So it had ribbons of hyaluronic acid and it had bits in it. And the advantage of the Restylane was it lasted quite a long time because it had bits in it. But the disadvantage was that it did not blend in with the skin. So if you put it under the skin, it would give you Tyndall effect because the bits would refract the light differently. So traditional Restylane probably gives the most Tyndall effect of any of the fillers. Actually, the Restylane, there used to be one called Perlane. It's now called Volume, but it used to be called Perlane. So these were the 2 Restylane products that were of the original particulate first generation fillers. And they didn't integrate well and they caused Tyndall effect. You'd get little grey circles wherever you put it at one time. And the second generation fillers came along and they had no particles and they were just gels. And you'll remember the second generations were Juvederm Classic, the Teosyal Classic, the Restylane had a brand called Emavel. They were what I would consider to be second generation fillers, where they were gel-like and they didn't have particles and they integrated slightly better with the tissues. So that's what second generations were. And they got their longevity by cross-linking. So the more cross-linking they had, the stiffer they were, the longer they lasted. Okay. And then we got to products like the RHA range, where the chains became longer, like our own natural hyaluronic acid, but they had less cross-linking. So long chains with less cross-linking, so that you got longevity, but they also looked and felt natural. They integrated properly with the skin. They were more like your own natural hyaluronic acid. And there are a number of third generation hyaluronic acids now, but the Teoxane range has the longest chains, most like your natural hyaluronic acid. most natural, integrates perfectly with your skin, so that you can have a face that's nearly 60 and it still moves like a normal face. I mean, I owe my face to RHA, so I speak about it with personal passion. Okay, that you can have these products that just make you look so normal, don't look like your face is full of filler. And it's due to the long chains with the minimal cross-linking. So the degree of modification compared to the old versions, which were 5 to 10% cross-linked, maximum 4%. Okay. By keeping those chains long, it means that there is more dynamic movement. And there are other products out there that have less modification, but their chains are shorter. And we know that short-chained products create more inflammation in the skin. Long-chained products create less inflammation. And what do we use for the tear trough? Well, we know that Redensity 2, which some of you will be getting in the next few months, some of you have already had the joy of using it, attracts very little water and spreads evenly through that deep intramuscular supraperiosteal layer. Compared to the competitors, it's got the least amount of water being drawn to it. It's the least stiff, and it spreads the best. So all the things that you want from an under eye filler. Dozens of clinical papers that actually support, this is not just me saying it, there are clinical papers supporting this. And of course, we have these nice other ingredients in the product that help with the hydration, the elasticity, and the radiance of the skin. Just to show you what happens when you don't use the right products. So both of these, this is filler migration from product being put here and has migrated. This is misplaced. This is the wrong product. This is one of the second generation fillers that has been put here, and it's just expanded 2 weeks later. So this was 2 weeks after she was treated that she looked like this. And when you do it with Redensity 2 and you do it a mid-face treatment and you do your lateral aspect of your tear trough with Redensity 2, this is the kind of result that you can get. Unbelievably smooth. This is one of my patients, one of my treatments who had her mid-face. And I'm just going to emphasize to you, she had no product put in her direct tear trough, only in her lateral tear trough and her mid-face. Okay, and she was in her late 60s when we did this treatment. And finally, don't neglect the skin. That top surface. Teoxane have the most incredible range of dermaceutical products that have the same RHA technology in the product. So when your patient is paying to have this product in their face, they can also have this product on their face. And that R2 Eyes product, it has this beautiful flat applicator. So if people get edema or they have puffiness, the applicator actually gives them this sort of, it's not a roll on, it's like a flat applicator that gives you smoothing of the skin. Absolutely worth trying if you've never used it before. I give it to all my post-treatment patients. Just to remind you, the best results are not when you just treat one part of the face. The best results are when you blend it into the whole face. So you look at the thing that bothers them, and then you balance their whole face out. So this lady had 3 or 4 treatments over about a 3-month period. She had facial asymmetry, she had tear troughs. She's very thin because she's a Pilates instructor. She teaches yoga. So she has no subcutaneous fat, and you can see that here and here. But what happens when you use the right products in the right part of the face? You can transform someone's face. Hopefully, we've got some questions, and we're looking forward to seeing you in a month's time with a few other things that we're going to do. We'll talk about temples, we'll talk about combination treatments. And hopefully, Nadia, I'm hoping we've got questions that you've been fielding through the talk that we can start answering.
I do. Thank you, Dr. Tahera, for the excellent presentation. I absolutely learned a lot. We do have some questions. Okay, the first question is from Dr. Aida from Jakarta. So she'll like to know, how do you check for edema on the under eyes area? I think this was pertaining to, yes, when you were sharing on a good subject criteria and a not so good subject criteria.
Okay, so edema is, so when you have some sort of puffiness and you think, is this fluid? Is it fat? Is it just loose skin? Because you can get festoons of loose skin that you think is fluid, but it's just skin. And you can get what looks like a bag of fluid when it's actually prolapsed fat. So there are a few ways of checking for it. Prolapsed fat, generally speaking, is on the lateral aspect. Because when the orbital margin changes shape with age, the lip is here. And that prolapsed fat tends to be here. So that's one clue. If someone has true edema, if you press on it and you wait 10 to 15 seconds and you take your finger away, you will get a dip. Because the edema will pit. Do you know how we check for pitting edema in the ankle? You can check for the same, it's the same sort of thing. You can just press it, wait for 20 seconds, lift your finger, and you can see a dip. So if there is edema, it's either just because they have fluid, or it's because they have filler that has got fluid. It could be either. So if they've had previous filler, then remember, subcutaneous fat does not collect fluid like that, but filler does. So that's something, there are a couple of ways of checking. The other thing is to do what I call a stretch test. If you pull the corner of the eye up, so you take away the laxity of the skin, and the skin is still bulging, then you know there is something causing the bulge. Whilst if you do that and the skin is flat, you know it's just skin laxity. So sometimes you see people with festoons of skin, but when you do this, their contour is perfect and you know it's just skin. Whilst if you do that and there's like a bulgy thing going on, you think, okay, even when I'm flattening the skin, actually the bulge looks worse. Then you know there is something else going on. So that's what they're just observational things that I use to tell the difference between fat and fluid. And prolapsed fat, sometimes you can push it back in. Fluid, it just squashes out between your fingers.
Got it. So 3 different techniques to check whether
different ways
edema
of assessing. And then experience. There is no substitute for years of fiddling with people's faces. One of the things I would, with all my heart, encourage you not to do is assess people on photographs. You cannot tell on a 2D image what is happening on a 3D face. Now, you can see beautiful faces on a 2D picture. You see them in real life and their lips are out here and their cheeks are, but when you see them on a photograph, it doesn't show. So just, you know, when patients are sending you pictures, I want to look like this, or I used to look like this, you take it with a pinch of salt. You assess them with their actual face.
Okay, thank you, Dr. Tahera. Okay, I have 4 more questions so far. We'll try to answer all of them, but will be time sensitive. So the next question is from Monica. So she asked, how long after injection can, I think her question means how long after injection, what kind of window do we allow for the filler to migrate?
Hey, interesting. So bear in mind, most fillers do not migrate if they are put in properly. But if you have product above orbicularis oculi, it can take anywhere from 3 to 12 months to migrate, depending on how much is there and where it was placed. So migration can happen with gravity and with movement. So sometimes product put in the superficial plane here will drop here. So you see it as a bulge here. It's not really migrated. It's not migrated from movement. It's migrated from gravity. The migration from movement often happens where the product is here and it ends up here. So, and that can take weeks or months. Normally, if it's only happened in a couple of weeks, chances are you put it in the wrong place, because it's not going to really move that quickly in a couple of weeks. So when you do your 3 to 4 week checkup, if it doesn't look like it's in the right place, you probably didn't put it in the right place. But true migration, you'll see in patients who had product maybe injected 12, 18 months earlier, and they haven't been back for treatment, and then they just come in routinely for something else and you notice a bulge. So one of the patients I showed you, I don't know, that's what happened with, let me just share my screen again. Let me just show you that one. Are you able to see that?
Yes.
Okay, so this,
sorry.
So
yes.
This lady, this was migrated product, this sitting here, because she had not had filler for 18 months and she came in for her toxin. She came in for her Botox and I said, what is this? Okay, I thought she had been somewhere else and had treatment. And she promised me that she had not. And I looked back at the notes and I had put some product here. And I think that this was migrated product from something she'd had here 18 months earlier. I mean, it's a very old slide. It's not a recent slide. But it was a product, not one of Teoxane products. I'm not saying it couldn't happen with Teoxane product. Migration can happen with any product. It just so happened this was not a Teoxane product. And it was put here and it ended up here.
Sorry, if
18
I may
months.
ask, this photo, the filler, was it under the muscle?
No, it was above the muscle. It was above the muscle on her cheek here, done with a cannula in a fan. Was the only explanation I can give for finding this. So you have to, because remember, orbicularis oculi in some people is a very big muscle. It comes down. Some people it sits like this. In some people it's almost square. It has a tail that comes here. So if you fan across the cheek, you can catch it here. And then you've got this. That's my only explanation for what happened here. That this was migrated product because I found some product in the cheek about 18 months earlier.
I would go on to the next question. Amelia asks, can you use Redensity 2 on periosteum or just on a superficial layer?
No, Redensity 2 is put deep. Remember when we're doing tear trough, we are going deep. We are not going superficial. There is no fat to disguise Redensity 2 or any filler in this part of the eye. So you are going under the muscle, as close to the bone as possible, with a needle or a cannula. Redensity 2 is used deep in the tear trough, and we are lifting the muscle closer to the surface.
Okay, thank you for that clarity. Okay, we still have a couple more questions, but I think I'll just answer one more so that we can finish on time. So, okay, what is the best solution or for a patient who has done filler in the mid cheek and tear trough area, but when she smiles, her nasojugal groove is still obvious? I think this is a good question.
That's a really good question. Okay. So now I'm going to tell you what I do, but I'm not suggesting that you necessarily do this. okay? Because remember, the nasojugal groove contains the angular vein, okay? So I pinch the skin so that I'm certain that I don't have any vessel there. And I take a very soft product like RHA1 and I just drop it under the skin. And I do it with a needle, with precision, with 22 years worth of experience. But that's how I treat it. You can see mine has been done. My nasojugal groove has been treated in that way.
Yes. As I was telling you, I can't tell that you've done anything to your face.
My whole face is full. With Teosyal products.
You look good, Dr. Tahera.
Thank you.
Okay, I think I will still try to answer one more question. Still, we have a little bit more time. This one is a quite interesting question from Atinuk. Last question that we will answer today. So the question is, Redensity 2 is better on bone. RHA2 under the orbicularis oculi. I think this is, she means that RHA2 in the deep fat pad. So is this accurate?
Okay, so these are rheologically different products. RHA2 has 23 milligrams of HA, will expand a little bit, and will, whether you put it deep or superficial, it will draw some water and it will give you some oomph, some padding. Okay. Redensity 2 has 15 milligrams of HA, and it will spread thinly and give you a little bit of lift. Okay, so when you are coming under a tear trough, under that muscle, you want something that will integrate with the muscle and lift. That's why I use Redensity 2 in this area. RHA2 you could put in medial soup a little bit because it will expand. If you're using RHA2 for that, you undercorrect because you know it's going to expand. You need experience with the product so you can guess how much expansion you're going to get. RHA2 is one of my beautifully favorite products because if you have a small area like, I don't know, the lips, and you want to go deep or superficial, you can drop it in the superficial fat plane and you get the most beautiful smooth results. You can do the little lines under the lip and just give a really nice shape to the lip without giving big fat lips. RHA2 is what I've had in my lips. Just under here, just up here, replacing the loss of superficial fat. You can use RHA2 in any part of the superficial fat plane and it gives you a perfectly smooth finish. So, but if you're going to put it deep, then you want to put it in a small fat compartment that has been lost, or you'll need a lot of it. But remember that it's going to expand. Redensity 2 for areas that you don't want to see fluid or expansion. RHA2 where it doesn't matter so much.
Okay, that is very insightful. Okay, thank you, Dr. Tahera. Thank you all the participants for joining us in today's webinar on the Teoxane approach to the periorbital rejuvenation. We're really grateful, Dr. Tahera, for your expertise as an eye surgeon and having the vast experience of doing facial rejuvenation for more than 20 years and sharing her knowledge and her insight and her tips to achieve positive outcome in treating this area. I believe for injectors like us, the methodological approach that she has shared, very structured sharing, to the periorbital rejuvenation results ultimately in a high reward treatment outcome for both the clinician as well as for our patient. So I would like to recap what are our key learnings with the ATP approach of anatomy, assessment, technique, and product. So firstly, we highlighted the importance of understanding the complexities of the anatomy, may it be the vasculature or the lymphatic drainage system of the periorbital region. And without a clear roadmap of this region, we may face challenges in not only achieving the desired outcome for our patients, and we might encounter complications. So Dr. Tahera has very generously shared her knowledge. She emphasized on the significance of a proper assessment, aging-related changes of the eye area. So by strategizing the techniques, namely the indirect and direct technique that she shared, targeted at these specific anatomical structures, the deep fat pad, the muscle, and the superficial fat pad, we can use the appropriate products and result in maximum outcome and minimize the risk of complication. And then finally, the takeaway, Dr. Tahera also debunked a very common myth that most of us doctors believe in, that all HA products are the same. Ultimately, it's not. Different manufacturing technologies will produce different filler rheology, and this is where I believe doctors need to do a deep dive and consider the selection of a right HA product, one with a long chain molecule, appropriate cohesivity, low hygroscopy, and optimal support for the soft tissue on our face is paramount for achieving successful under eye filler treatments. And I believe I am very much in agreement with what Dr. Tahera said, that we are doctors, we treat the underlying cause of what we see, not just the superficial symptom. So for further information of this treatment or what we have discussed today, I apologize we were not able to cover all the questions. Don't hesitate to reach out to your local representative. Stay tuned for the next webinar. We have our poster up here on the 20th of March, where we'll be exploring even more advanced techniques, and it includes topics that only a very experienced injector can share, of how to treat the temple, eyebrow, and also blending for full face rejuvenation with Dr. Tahera. Thank you so much again for your participation, and we look forward to continuing our educational journey together.